The next case, a toddler with murmur and displaced apex, is an example of a toddler with murmur and displaced apex beat. An 18-month-old child is referred for cardiac evaluation after a murmur. After a murmur was detected during a routine check. Examination revealed that the apex beat is palpable in the fifth intercostal space, in the left fifth intercostal space, with a pan-systolic murmur best heard at the left lower sternal border. The first heart sound is normal. What is the most likely diagnosis? Tetralogy of fallot, coarctation of aorta, ESD, hypertrophic cardiomyopathy, VSD. The correct answer is VSD. Explanation: a VSD commonly presents with a pan-systolic murmur at the left lower sternal border. So the VSD characteristic presentation is a pan-systolic murmur at the left lower sternal border. Pan-systolic murmur at the left lower sternal border. A displaced apex beat indicates left ventricular volume overload. A displaced apex beat. The apex beat is palpable in the left fifth intercostal space. So the displaced apex beat indicates left ventricular volume overload consistent with a significant VSD. Why the other options are incorrect? Tetralogy of fallot presents with cyanosis and an ejection systolic murmur. Tetralogy of fallot presents with cyanosis and an ejection systolic murmur. There is no cyanosis here. And an ejection systolic murmur. So the murmur is here during the systole and it's an ejection. The murmur here is pan-systolic. Pan-systolic. The pan-systolic murmur is characteristic of VSD. An ejection systolic murmur is characteristic of tetralogy of fallot. Coarctation of aorta causes radiofemoral delay and hypertension. There is a delay between the radial pulse and the femoral pulse, radiofemoral delay, and hypertension, characteristic of coarctation of aorta. ESD produces a fixed split S2. So whenever you see a fixed split S2, this is ASD, not pan-systolic murmur. The pan-systolic murmur, diagnostic of VSD. A fixed split S2 is a diagnostic of ASD. Hypertrophic cardiomyopathy causes a murmur that changes with posture. Hypertrophic cardiomyopathy murmur, a change with posture. So the murmur here doesn't change with posture and it's pan-systolic, diagnostic of VSD. This is an example of VSD, ventricular septal defect. This is a CT scan, CT angio, coronal cut, and axial cut. On axial cut, this is the right atrium, which is anteriorly located, and this is the left atrium posteriorly located, and this is the defect between the right atrium and the left between the right ventricle and the left ventricle. This is the VSD. This is a coronal cut. This is the left ventricle and the right ventricle, and this is the defect. Defect in the ventricular system. The presentation of VSD asymptomatic with heart murmur or tachypnea or congestive heart failure. The murmur is a pan-systolic murmur, as I mentioned. The complications is pulmonary arterial hypertension. The management here, if the patient is asymptomatic or due to a small defect, the small defect may close spontaneously. However, medical treatment is the treatment of the symptomatic larger VSD. The medical treatment is diuretics for afterload reduction, followed by surgical treatment. This is an example of ASD, atrial septal defect. These are MRI images showing a defect in the atrial septum between the left atrium and the right atrium. In ASD, the blood flow will go from the left atrium to the right atrium. This will lead to right atrial enlargement. There are two types of ASD. Ostium primum and sinus venosus. This is the ostium secundum. So there are three types: ostium primum and ostium secundum and sinus venosus. The presentation of ASD, usually asymptomatic, can be presented with heart murmurs. As I mentioned, ASD is characterized by a fixed split S2. The complications of ASD is pulmonary hypertension, the same as VSD. Due to shunting of blood from the left side of the heart to the right side of the heart, this will lead to pulmonary hypertension. And the paradoxical emboli, the management is none for small defects, as I mentioned in VSD. The small ASD will close spontaneously. Endovascular treatment, transcatheter, percutaneous closure device, or surgical treatment for a large ASD. This case is an example of tetralogy of Fallot. On the chest X-ray, there will be boot-shaped heart and pulmonary oligemia. So the characteristic features of tetralogy of Fallot on X-ray, the boot. So the characteristic features on the chest X-ray is the boot-shaped heart and the pulmonary oligemia. CT, angio, and MRI will show the four key anatomic features: subvalvular or infundibular stenosis, valvular stenosis of the right ventricular outflow tract. So the most common features for tetralogy of Fallot on cross-sectional images. The first one is the VSD, ventricular septal defect, and the second one is right ventricular outflow tract stenosis or infundibular stenosis. Then the overriding aorta, and the boot-shaped heart. Cyanosis is the most common symptom in tetralogy of Fallot, and also in the history, squatting. Just give me 1 minute. Squatting improves dyspnea on exertion. So the child will be cyanotic, and squatting will improve the dyspnea. The management here, surgical treatment. Right ventricular outflow tract stenosis should be corrected, surgically corrected. The VSD should be closed surgically. So that's it. Okay. This is an example of hypertrophic cardiomyopathy. On MRI, there will be left ventricular wall thickening, maybe symmetric or asymmetric, left ventricular wall thickening, involving the basal, middle, apical, or septal aspects. Here involving the septal aspects of the left ventricular wall. It also can involve the apical aspect, which is not involved here, or the basal aspects. So here the septal myocardial wall is thickened here. Left ventricular outflow dynamics to detect the obstruction. So here this is the image in the systolic phase during the systole, and this is the image during the diastole. There's no difference between both image. Indicating diastolic failure. Also, there will be delayed contrast enhancement within the hypertrophic regions. Delayed contrast enhancement within the hypertrophic regions, particularly in the mid-interventricular septum. In the mid-interventricular septum, there will be delayed contrast enhancement in hypertrophic cardiomyopathy. There are two types of hypertrophic cardiomyopathy, obstructive type and non-obstructive type. The non-obstructive type is the apical hypertrophic cardiomyopathy. The obstructive type, there will be left ventricular outflow obstruction due to asymmetric septal hypertrophy, known as the obstructive cardiomyopathy. So, if the septal portion of the left ventricular wall is thickened, this will lead to obstructive cardiomyopathy type. If the apical portion is thickened, this will lead to non-obstructive cardiomyopathy. The complications here may be sudden cardiac death in young athletes. This is very important. Sudden cardiac death in young athletes due to left ventricular outflow obstruction. Sudden death in young athletes, likely from ventricular arrhythmia and left ventricular outflow obstruction. The management, medical therapy and surgical. The medical treatment, beta blocker or calcium channel blocker to improve the diastolic relaxation and to reduce the likelihood of arrhythmia. So the medical treatment of obstructive cardiomyopathy is beta blocker or calcium channel blocker to improve the diastolic relaxation and reduce the arrhythmia. Surgical treatment, which is septal myomectomy. Septal myomectomy or endovascular therapy when medical treatment fails. This is an example of coarctation of aorta. Chest X-ray showing frontal chest X-ray frontal view. There will be flow limiting stenosis of the aorta resulting in post-stenotic dilatation. Figure of 3 sign, rib notching. Can you see the rib notching here? There will be inferior rib notching, and left ventricular hypertrophy. There will be on esophageogram lateral view, there will be reverse figure of 3 sign. So there will be figure of 3 sign of the aortic arch and reverse figure of 3 sign of the esophagus on esophageogram. On CT scan, contrast enhanced CT scan, there will be focal narrowing of the aorta. Focal narrowing of the aorta with post-stenotic dilatation. With post-stenotic dilatation of the descending aorta and collateral vessels. Post-stenotic dilatation of the descending aorta and the collateral vessels. The collateral vessels will lead to the inferior rib notching. The management of coarctation of aorta. If the patient is symptomatic, surgical reconstruction, balloon angioplasty can be performed. So we have 2 options here, surgical reconstruction or balloon dilatation of the stenotic part, balloon angio plus T.